First of all, I'd like to introduce the moderator, Professor Vitoon. So we will moderate this session together. I'd like to introduce our discussant today. Today we have three discussants. First is Professor Songphol Malakorn. He is instructor in Colorectal Division, Chulalongkorn Colorectal Research Unit. And right now he's an assistant professor and vice director of the research unit in this university.
The next one, Professor William Chen. As we know yesterday, he's a professor of surgery at the College of Medicine, China Medical University at Taichung City, Taiwan. He also the member of American Society of Colorectal Surgeons, board member of APELS, as well as AETF, and also the many society and association in Asia.
Lastly, actually no need for the introduction, right? Simon, my good friend. Professor Simon Ng is a chairman and professor at the Department of Surgery, Division of Colorectal Surgery, Faculty of Medicine, Chinese University of Hong Kong. And he's also the professor at the Institute of Digestive Disease, State Key Laboratory of Digestive Disease, Faculty of Medicine, Chinese University of Hong Kong. Right now, he is the president of Hong Kong Society of Proctology, and so many. I'm gonna spend the whole day. You know, he hold so many important points in many leading society. So today we will have fruitful case discussion for sure. Let me introduce our presenter, Dr. Kit Ravi. He's gonna run through all these case presentation, and during the case presentation, I like to invite all comment, all points from the audience. So please feel free to make any point of comment. Shall we start? Okay, let's kick start.
Okay, thank you for the introduce. The first case for today, we will start now. Our patient is a 52 years old male patient. His BMI was 24.7. He presented with a bowel habit change. After digital rectal examination, we found a circumferential mass 4 cm above the anorectal ring, not fixed, good sphincter tone. After the colonoscopy, we found a circumferential mass at mid to lower rectum, and the pathologic result is well-differentiated adenocarcinoma. He got the neoadjuvant chemoradiation, total 50.4 gray, 75 fractions with capecitabine, and complete 10 weeks before the surgery. Here is the imaging. The pre-concurrent chemoradiation is MRI rectum. The sagittal view.
All right. At this point, I like you to move back to the pre-CCRT, the axial view. Yeah, at that point. Yeah, like that. So obviously, in this case, you notice that the patient has EMVI, and EMVI reached the circumferential margin at 8 o'clock, and you see some fluid accumulation at the pre-sacral area, and some questionable of the CIM threatened at the 6 o'clock or so. So at this point, actually this is a case that we just we operate on already. So can you bring back to the preoperative treatment? Now, in this case, I like you guys to comment on the specific point in this case. Any comment from the discussant?
So I think it's, thank you, Chucheep. Thank you for your presentation. I think there's a pretty typical case that we see normally in our MVTs, right? So it's a 52-year-old male. BMI, I noticed that is 24. Is it normal, considered normal in Thailand? I'm not sure. Quite normal, right? It's, yeah, okay. And I think in Hong Kong is around 20, maybe our patients 23, 24, all right? Although we do see more obese patients. But this is located in the mid-rectal tumor, 4 centimeters from the puborectalis level. So distal margin, I think, is not a concern. I think just from the CCRT MRI, obviously, the mesorectal fascia is threatened, obviously. So for sure, we're going to offer a long-course chemoradiation therapy in this case.
Agree with Prof. Simons. The EMVI actually present is a high risk of the distal metastasis too. So I think here, if we start with the neoadjuvant chemoradiations concurrent with the capecitabine, it's long course, I agree. And then I think maybe we can add the consolidation chemotherapy because of the risk of distal metastasis owing to the very thick EMVI.
So is it a norm? I mean, obviously you can give a chemo RT first and then you evaluate, all right? Obviously, if the EMVI has resolved and if the margin has improved, I'm not sure, probably in Hong Kong, we may consider just go ahead for surgery instead of giving consolidation. Usually for those patients of whom the margin is still a bit of concern, because obviously if there's response, you see a lot of fibrosis on the MRI, but obviously on DWI, they may be able to see some still residual focus. For that, we may consider adding on consolidation. All right, so we need to see the post CCRT MRI, and then we'll decide whether we'll add on consolidation. So is it a common practice here to do induction CCRT and then consolidation? I mean, in the form of a TNT.
It's not routinely doing that consolidations. That's true that as you said, if the post-treatment MRI still have the critical margins, we're gonna do. But what we do is sometimes when we wait like 12 weeks after the last radiations, we can add up just some, not like a full ETNT. Like it's just some, 2 or 3 cycles, something like that. Yeah.
So when do you normally arrange your re-evaluation MRI? I mean, after the completion of the CCRT?
Usually 7 to 8 weeks.
Oh, 7 to 8 weeks, okay.
Shall we move on to the post-CCRT imaging?
And we normally reevaluate after the CCRT, like 8 to 10 weeks. In this case, it's 10 weeks after CCRT, and this is the imaging.
All right. So could you please bring back to the axial plane again? Okay, in this case, after the CCRT, you see the response of the tumor now it's become shrink, but you still see the black signal at the margin. At this point, what is your opinion and what is your suggestion?
What is the colonoscopic view?
we still see the ulceration.
Because I can't see there's no colonoscopy view on this.
No, we
So-
don't have it.
So there's still an ulceration there.
Yes, still not CCR.
It looks like the preoperative pre-treatment MRI shows lots of reaction fluids behind the TME plane, right? And then now the fluids come like gone, just a little bit there, but still, I think the margins is still threatened, especially on the right posterolateral. If we have to do surgery, I think we have to go like beyond TME at that part, especially on the right side.
Do you consider PET scan on this at this stage to see whether that's a cancer or that's a fibrosis? Would you do that?
In this case, we didn't do that. We look at the MRI image and the colonoscopy to see whether it's turned to be CCR or not. But obviously, in this case, after the radiation, when I did the rectal examination, still feel some fibrosis and some ulceration, and colonoscopy reveal some ulcer.
Yeah,
So this is not complete response. So
No.
what?
So if we wait longer, do you think the response will be better?
Okay, so that should be discussed in our in this.
And how long?
Yeah.
The longer mean another 3 months?
When
or-
was this? 7 weeks, right? Or 8 weeks?
This is 10 weeks.
8 weeks.
10
I'll
10
wait
10
4
weeks.
more month. I mean, four more weeks later. Usually, I wait for 10 to 12 weeks before I do any images. Usually 3 months after the previous image. So I'll wait longer.
Right. Well, this, in Hong Kong, usually will be reported as margin threatened by fibrosis, maybe, right? So they just, because somehow you can't differentiate. And I'm not sure whether you have the diffusion weighted imaging, DWI. Was there restricted diffusion, or what did it say on the DWI? Any restricted diffusion?
So in this case, it's still state that it's still some questionable tumor cells.
All right, so it's still got some restricted diffusion.
Yes.
This is why I will do a PET scan. As a PET scan. To confirm whether it's fibrotic or. I'll wait longer.
Yeah,
I probably
Will you
wait longer.
consider to do biopsy?
No, I won't
No.
do biopsy for this kind of
No,
cases.
for the margin, you always cannot tell. I think sometimes even for PET scan, we'll not be able to tell, in particular, if you're talking about maybe microscopic. So I know this report is TRG 3 or 4, maybe 3, right? Usually 3 or 4 after season. So at this juncture, I think the surgical team has to decide whether you are happy to go in. I mean, if you go in, you need to do beyond the TME plane. You take the side as well. Otherwise, the other option would be since you're considering waiting, then probably you add on consolidation if you're not certain about the marginal status. So I think it's a matter of discussion in your MDT.
So if I'm waiting, I probably will play some IV chemotherapy I mean, this is my point of view, my own point of view, but there's any solid data to show that if I place an IV chemotherapy, it would be better. But as for my case, I would add, if I don't place some IV chemotherapy, I would add oxaliplatin.
Michael, would you like to add some comment?
Last question, whether there was any thinning of shortening duration on medium dose. Okay.
Yep. In this case, the location from the anal was still same, but I you mean the leg? It shrink. It shrink.
Yeah, the primary tumor seems to have response, all right?
Yeah,
So it's a
response.
decrease. So I think it's TRG3 maybe for primary tumor.
Yeah.
EMVI also has regressed, but it just that it's still the margin is still, you know, it's just dark. You're not certain whether it's fibrosis, whether there'll be fibrous tumor cells. So that's always a problem in MDT. You know, no one can tell. No one can tell. So at the end is whether you just bite a bullet, go in and take it out and look at the margin, or you wait for a longer while, add on further cycles of chemo. So that's the decision between these two options, I think.
Because in this case, we still the CCR believer, and we do the watch and wait to the case who fit for the CCR, but be so strict to the criteria. That means the criteria for the CCR apply to the case that we gonna enroll in this protocol. That means it has to be smooth, without ulceration, no palpable lesion at all. In that case, we would put the patient into the watch and wait protocol, but it has to be very serious discussion about the result, because in some point it might turn to be the regrowth. So in this case, particular case, the examination is so obvious that it's not fit for the CCR. That's why we.
When do we define CCR at what week? There's no definite timing of defining CCR after chemoradiotherapy. Is it 8 weeks, 12 weeks, 16 weeks? That you define as a CCR and you're gonna wait. There's no definite criteria or anything that around, I mean, the guideline tell you that this is a CCR and we can wait, right? But this case is 4 centimeter from the anal verge. There is a possibility of altering the function of the patient. Either he or she is gonna, either he is gonna receive an APR, or you're gonna perform a sphincter saving procedure. So this is a very interesting case to discuss on.
Yeah, obviously this is not CCR on clinical, on endoscopic and MRI is not a CCR at all. So William has raised a very interesting point, is that you're correct. The longer you wait, probably you see more response. So, but on clinical trials, I think they have definition, right? And based on that, and obviously they also look at whether the CCR is sustained. All right, if you can sustain for beyond a year or so, I think that's will be they'll just carry on with the watch and wait.
I think for tumor of T3 and beyond, to have a complete CCR, it's very unlikely. So I think the patients still need to have the thing out.
Yeah.
I would be happy to observe. I mean, your T1 tumor maybe.
I agree with Prof. Michael too, because T3 in our center is very rare to get the CCR, even though we got give them the consolidations and long course chemo radiations. So, and then the tumor regrowth in the data shows a lot of regrowth in the T3, and then lots of lymph nodes and EMVI too. So I think, and then in this case, I think we can keep the sphincters.
Yeah, that's wholesale from people rectalis, so for sure we
right.
can keep the sphincter. That's
Yeah, I think our opinion maybe go ahead doing the sphincter saving procedures.
Right.
So now it's come to the meat of the discussion now, because seems that we about to go for the surgery. So may I ask you for the approach, what particular approach that you think is gonna be the critical point, and what approach that you think is would fit for this patient? May I start with Simon?
Now, for me, if I see this case in Hong Kong and if I decide to proceed, right? If I'm, if we think that the margin it's okay, or it's more favor the negative side, then we just proceed. For me, choice would be robotic. I would do a robotic and probably on the right side, probably just try to take the fascia as well. I mean, just go beyond the normal plane to take deeper, because I think that's the suspicious area. Although I'm inclined to think that this might be negative, but I'll just try to play safe and just do a slightly more lateral dissection. But for me, it would be robotic, obviously, this case.
Will you consider TATME in this case?
Now, although I presented our results, all right, obviously when I was doing the trial, there will be randomizing patients, all right. But in actual fact, TATME and my unit, now, there are basically three types of surgeons, okay, who, how they see TATME. One would be those surgeons who actually routinely use TATME, regardless of, difficulty or stage, because they are firm believers of TATME. They believe that TATME is going to offer a lot of benefits. So that's one. Second is there'll be surgeons who are more selective, all right? They do TATME, but not for all cases. They'll try to select those more difficult cases, like obese, really the low-lying tumors, narrow pelvis, things like that. So selective. And the third would be those actually they are using TATME just as a salvage. So they'll just proceed with top-down anyway, be it a laparoscopic or robotic, all right? And then whenever they encounter difficulty from top-down, all right, then they just refer to TATME as a salvage or plan B, all right? So for me right now, my personal view is that I'll use TATME mostly as a salvage, because robot basically, I think William also agrees, we can do most of the cases top-down, even for some of the difficult cases, but we still encounter cases that are difficult even with the robot. All right, that's my experience. So for that, we'll refer to the transanal dissection. So using that as a salvage.
I prefer laparoscopic or robotic, and robotic will be my preferable technique, because robotic is more stable as a camera as you work down in a pelvic. I think that's a perfect tool at this moment that I think it's better than laparoscopy for the specific low rectum. With a BMI of 24, yeah, I think the robotic surgery would be proper. And if I cannot have the distal margin, then I'll go for a rescue TATME. Like I say in my talk, I always use TATME as rescue TATME. For example, it's to make sure that my distal margin is okay. Secondly, if I have a difficulty from the top, I would use a transanal method. But to me, a transanal dissection, it's not easier. It's not easier. It is never easy. Because once you go into a wrong plane, like me, I can go into a wrong plane myself. I mean, I've been doing many laparoscopic surgery. And once I get into that wrong plane, I mean, the patient will be devastating. So I don't like TATME because, first of all, I'm not too sure that I can get into the right plane every time. But from the top, it's something that I do for my life. It will be easier, and it's really easy, right? It's just like driving. If I'm driving on the right side, it will be harder for me.
Yeah, laparoscopic or robotic, I think is the same. It's just a tool because, but the key things is the plane. I think here is we need to know that actually the TME there's so many plane actually. The dissection line along the TME fascia, the parietal fascia, or above the nerve, below the nerve, or precursor fascia that going to with the specimens. So here, I think the one who want to deal with this case need to know all the plane. I think we have to go out the usual plane in this case.
The pre-hypogastric fascia as well. It's go one layer beyond the normal TME plane at least. But if we go too deep, then obviously sacrifice the nerves as well. So it's on the your intraoperative findings.
Yeah. So it seems that we have the agreement from our discussion that they prefer top-down in this particular case. All right. Shall we go to the operative image? So in this case, we start with the top-down. So we start from mobilizing the rectum, and you see the nerve that we preserve, and still in the TME plane. At this point, you see the juicy plane because of the fluid accumulation caused by the inflammation. Remember that we have the difficulty at the 8 o'clock location. So that's why we leave that part for the final dissection. So we start the dissection on the left side first because there is no critical point there. We still leave 8 o'clock for the last. This still in the TME plane. And now we about to go beyond it because it's come to the point where the suspicious lesion might already invade the TME plane. So we start to scroll on the fascia covering the presacral bone. The presacral fascia dissected with the tumor. And by doing that, we can dissect more on that point. This is the issue. You see the pelvic side wall there. So I start to go into the beyond TME plane, the fascia. And later on, I go back to the TME plane again. So you see that that is a TME plane, the presacral fascia dissected together with the tumor. And this is the normal plane right now. And this is a usual image for whatever we use, the robotic or the laparoscopic. Now we start to see the pelvic floor. And at this point, there is nothing now because it's below the tumor right now. So here's the pelvic floor. And it's ready for the transection and anastomosis. All right. Okay, we may have some comment on this. Let me show you the specimen. So this is the specimen on the front, but the issue is maybe on the back. Here's the back. You see that the fascia. Let me see. Sorry. Okay. So you see on this image, this is the fascia that we dissect with the TME plane. This is a normal TME plane, right? But this is a fascia that we dissected together with the specimen. So we go extra TME in this case, and it turned out to be T3N2 cancer. So at this point, you like to add on some comment on the technique, why? Simon.
Congratulations. Well done. So finally it's margin free. I think it's great technique. All right. So it's wise to take, a plane further away from the normal TME plane in order to ensure a clear margin, of which you have done it nicely. All right. So I agree with you. It's lab or robotic, just an approach. Depends on which you are more comfortable with, obviously. I'm sure both will produce a very good quality specimen in experienced hands. So it doesn't really matter whether it's a lab or robotic. It's kind of personal preference.
Well, congratulations on the excellent surgery. And as for the audience, I don't know if you listen to Chucheep. He just say that he started from the left side. The 8 o'clock, he left it for the very end.
Yeah.
This is called the subtraction surgery, which Kay will always talk about. You come from a nice normal tissue instead of attacking the point. At the end, then you achieve a very good margin. So that's a point that Chucheep was like telling everyone that when you do surgery, you go away from the lesion and find the normal tissue and come in with a very nice pain. Thank you very much.
So we have limited of time. So shall we move to the second case? Okay, please.
Yeah, thank you. So the second case is a male patient, 26 years old, with underlying disease. His BMI was 18. He was a non-case advanced CA colorectal with the right lateral pelvic lymph node enlargement and liver segment 7 metastasis. This digital rectal examination showed a circumferential mass 4 centimeters above the anorectal ring, not fixed, with good sphincter tone. Colonoscopy showed a circumferential mass as rectum, and pathologic results report the moderately differentiated adenocarcinoma. He got the MSI study too, and it showed MSI stable. And he underwent the induction chemotherapy for FOC regimen with anti-EGFR, nimotuzumab. And then he got the neoadjuvant chemoradiation, total 45 gray, 25 fraction with capecitabine. And later on, he got the capecitabine and nipocalimab as a consolidated chemotherapy. After that, complete 10 weeks before the surgery. And here is the imaging. Well, this is first imaging is of our CT or abdomen. I show you this is where the lesion is. So this is a circumferential thickening. Here is circumferential thickening, and here is a full circumferential here. And then you can see the really large lateral pelvic lymph nodes. There should be internal iliac node. And then I show you what liver metastasis look like in this case here. Segment 7. Okay.
So let me give you some more information. So this is a gentleman from Pakistan. At the first glance to me, he looks so thin and loss of all his energy because of very bad news to him. Anyway, the metastasis is just oligometastasis, just one location. Actually, he brought the PET scan from his country also. It's look just only one metastasis in the liver area and the lesion in the rectum like that. So in this case, we work with the oncologist, and this is what the patient got: the induction chemotherapy and targeted therapy. So what would you suggest or any comment on this? May I start with Simon?
So can I ask, have you done other molecular analysis apart from MSI? Other molecular markers, KRAS, NRAS, sequencing, any other data as well?
Yes, KRAS wild type.
Wild type. Okay, good.
And why did you choose Nemo?
It's hard for us because it's not chosen by us. But this is by the oncologist. When we consult to the oncologist, we will let them yeah. So
If
So many
this,
protocol, I think, in their study, I think.
Oh, okay.
okay.
A study.
This will be very, it will be, I myself will do FOLFOX series with panitumumab or cetuximab for this particular case. If you're gonna downsizing or for it, then this is my point. And secondly is I would do a liver first surgery and then move on for radiation and like a TNT protocol. I'll do a liver first and wait, because it's the time that we wait. While we're waiting, we do radiation. That's a different way to practice.
That's interesting point, because we still have the time after radiations. That time we can do the liver first, but in this particular case, it's just the single lesions. Sometimes I would let the liver surgeon do first if the lesion is very small, and then they want to do like 2-stage liver resection, and then sometimes they want to do something first, and then they're afraid of the tumor disappear after we give the consolidation chemo. So, but in this case, I think that the tumor in the liver is big enough. I think that we can, and actually we can do the simultaneous resection too. So I agree with that strategy.
Yeah, I think I think it's very sizable that here. Yeah, it's like segment 6 to me, 6 or 7. But anyway, I think I agree with the concept of giving induction, because this is a locally advanced tumor who's got oligomets, young age. I want to give more chemo. All right, I want to give more chemo anyway, so it's correct. Back home, I'll start with the induction chemo, 4-FOX series as well, because we're running a trial. So it's like the Prodigy 23 protocol. We give 4-FOX series and then long-course chemo radiation therapy. Now, the sequence, I think it's debatable. I agree with William, maybe, yeah. Now, for the trainees, I think it's always in FRCS examination, this is a standard question. If you have a synchronous liver mets, rectal cancer, what would you do? All right, you do liver first, rectum first, or synchronous. Model answer is, if liver is easy, you do liver first. Rectum is easy, you do the rectum first. Both are easy, synchronous. Both are difficult, chemo first. So that's a standard. Now, for this case, liver is easy. But the primary surgery entails now, because this one I think entails a lymph node dissection as well. All right, to see, well, the question is how you see lymph node dissection. Is it a difficult task, or you think it's just a straightforward, just a routine practice? If that's the case, then probably you may consider synchronous, because the liver is easy, and if you don't consider the rectal part, including the lymph node, as difficult, synchronous. If you think that the rectal part is more complicated, you can consider going for liver first. So it's debatable here, but if you think you can do lymph node dissection easily in a quite straightforward fashion, minimal mobility, synchronous, I think is okay for this case.
My point is, do you consider this as a localized disease or as a systemic disease for this case? Probably it's a systemic disease. Secondly, for the rectum, you have a large pelvic lymph node, which we have to wait, right? After radiation, we have to wait, we have to see and observe. So doing the liver is easy because it's a segment 6. If it's a segment 6, it's really easy. You can just do it. Yeah. And after the liver, we can wait, and then we survey again if there's other livers while you're waiting that develop other liver metastasis. And while we're waiting for the rectum to be easier to operate, and after radiation, and we have to wait anyway. So that's my point.
Yeah, I think I do agree with your comments. In general, the discussion and the final decision will be made upon all of us. I mean, the surgeon, the colorectal surgeon, liver surgeon, and also the patient. The patient also, because this has to be all agree. But I asked the liver surgeon about what is his opinion on this. He said liver first is okay, but it's so small, it may take like an hour or two. So if you like me to just take it out, I can do it for you at the same time. And the patient like to do that also, because this is the discussion that we all agree.
The other thing is the patient is 26 years old, and the MSI status is very important, especially in this era. I think the neoadjuvant immunotherapy, there's some role in this case too.
Okay, shall we see the post treatment image?
So this is imaging 8 week after the CRT. Here is a previous primary tumor site. You can see the fibrosis around the tumor. And here's the lymph node.
The node is still the same.
Yeah, this is axial field. And this show the coronal vein.
Node might be smaller if we give like Cetuximab. I think. Right? If we give Cetuximab, yeah, the wild type.
Okay. Now you can see the lateral node that seem to be really a little response or not?
At 1 week is this? At 7 or 8? 8 to 10 weeks.
Yeah.
Would you add target therapy for this?
Yes.
At least for twice or 3 times? 2 times, I mean, see if it responds.
But you give the consolidations, the targets too, right? After radiations.
Yes.
So at this point, we see that the primary tumor responds so well, but the lymph node is still there. What is your opinion on this? May I start with William?
Yeah, like I say, I'll place patient 2 to 4 times of target and sulfoxyl for this particular case before I go ahead for surgery. Yeah. While waiting, my liver is already out if it's my patient.
So you still will like to proceed with the liver first and then add on.
I do a lot of liver first because a lot of time, if you look at literature, synchronous resection of liver has poor outcomes. Because it ended up with later on will develop a lot of like recurrent liver metastases. If I do liver first and I wait for a while and see if there's any development of other recurrence, and then I'll do the rectum. If there's a lot of recurrence, and that's it, I wouldn't do any surgery.
Using quad-trap neoadjuvant chemo, there's some data shows that there's some benefits especially in the young patients who can receive lots of chemo.
That's right.
Right. The quad-trap is reasonable in this case to agree. And if we have the MSI, we're gonna have more idea about giving the either like immunotherapy too, something like that. But the problem is, I think that the nodes itself not smaller at all, and maybe I think it's getting bigger too. It's gonna be very, very hard to do the lateral node dissections in this case too.
Simon,
Yeah, can I ask about the liver? Is the liver okay right now? What's the status of the liver?
liver is okay.
Yeah, so it's responding.
Yeah, response, but still there.
Yeah, okay,
You still
good.
see the liver.
So the primary tumor responded quite well. Just at the lymph node, I agree. I actually don't see a shrinking in size as well as the same. So now if you're contemplating a lateral nodal dissection, in this case will be difficult because it basically occupies almost a whole lateral compartment. I think it's the internal eyelid will be difficult. But I'm not sure, giving further cycles will really shrink that lymph node. Even if it shrinks, I think it's still a lot of fibrosis. I think the surgery will also be difficult if we pursue the lateral lymph node dissection in this case.
Okay, so in this particular case, with the lateral nodes and the tumor in the primary location, which look pretty good, response become smaller. The margin of the rectal resection seem to be very good, but the lateral node there. So in your ideas, what is the approach that would you select for this case?
For me, I obviously would prefer robotic approach as well. So I feel using a robot and doing a lateral nodal dissection would be easier and more comfortable. In particular, in this case, I think it would be quite difficult. All right. So robot actually offers quite good, a very stable traction and counter traction when we're dealing with the nodal disease in particular in this case. So I'll just go for robotics maybe. And of course, if we talk to Masaki, Ito will be transanal, including the transanal pelvic lymph node dissection for him. All right. But for him, I think, well, this case will also be difficult for him. I think it's because it's not the obturator, I think it's internal iliac. So, but for him, I think it would just consider transanal. But for most of the other people in the world, I think it's either will be a laparoscopy, all right, or robotic.
So because you have case that you operate on with the liver surgeon as the simultaneous, right? So in this particular case, if you plan for the robotic, what is your liver surgeon prefer?
No, Yeah, I think they will be robotic as well.
So the port size is going to be a bit different.
Yeah, additional port sites. Now, of course, I think it's, I'm not sure I cannot speak for them, but they can do robotic, obviously. But maybe since there's just a segment 6 or 7, just a wedge, they can also do laparoscopy.
Robotic for both, because once you use the robotic, patients spend the instrument part, or yeah, they have to, we have to stick with it. Secondly, I would do robotic for all the lymph node dissection and rectal resection. But if it's for K, Uehara, she will probably prefer laparoscopic. Yeah, because she wants to have the sensation, the feedback. Although she's also a good robotic surgeon, but she told me with this kind of cases, she would rather to have laparoscopy. So she did a live demonstration on a patient on this a large lymph node as well. So she preferred robotic, which was challenged by everybody. Why don't you do it robotics? If myself, I'll do it robotic.
Can I ask a question? For laparoscopic surgery, you guys use 3D or just routine 2D imaging?
We don't have 2D image anymore.
It's all 3Ds.
Yeah. In my hospital now, I don't have 2D. I don't have 2D. I only have 4K.
4K, 3D.
4K and 3D.
Well, I mean, that's another essential point of doing deep pelvic surgery. I think if you don't have the robot, get the 4K 3D imaging, it really helps a lot.
I think using the laparoscopic surgery for the lateral node dissections, most of the surgeons they get used to do the lateral node dissection on left side is more comfortable, especially for the laparoscopic. For the right side, laparoscopic surgery should be a bit tricky, right? Yeah.
No, let me add this. On the right side, you gotta place a different port. Okay, you gotta come to the left side. Like we used to do open surgery. So when on the right side, I would add an additional port to make it this way. So there's always easy if you change your position, a laparoscopy. Nobody say where you have to stand, but nobody say how many trocar you have to place on. So I think adding an additional trocar and coming on a different side will be an easy one. And just adding like a 3D, we prefer using our in colorectal, we prefer using Olympus 3D for all our colorectal surgery. I was once proposed to them that why don't you use those? Everybody vote against me, so we like to use Olympus flexible 3D. Yeah.
I think I saw one of Professor Ito videos and his comment on the right side lateral node dissections. He said if he can go from below, the right side lateral node dissection is easier, but
It's hard. Yeah,
that's right. So he do the left side from above, but do the right side from below. That's what from Ito. And I never see anyone who can do the lateral node dissection through the TATME dissections, except Prof. Ito.
And also probably Uehara as well. Maybe Takemasa, I don't know. A few of them in Japan. I think they are probably the few who would do transanal lymph node dissection only.
On the right side, right?
Yeah, that's very true. I saw his videos mostly on the right side. He just enter S4 level and then see the operator right away. So it's easy for operator, but internal eyelid will be hard.
But for laparoscopic right side, change to the left side. And then your cameraman comes through. So it will be easier.
Yeah, exactly.
That's what we do.
For robotics will be pot hop. You hop to the other side. It's the same concept. Yeah.
Not a big.
No.
Choke optics. You gotta put it more of a like this and do your spin pressure with the laparoscopy and then you do the robotic. You see every innocent when they do both sides.
That's
they
great.
place it straight.
That's right. That's right.
Okay, so I like to conclude that all comments from the discussion that they all agree to proceed with the top down. No one like to start with the bottom
We
up.
have bias.
And this is some tricky case because the tumor located on the right side, which not only the laparoscopic approach but the robotic approach need to be rearranged a bit for the location of the pot placement. So in this case, we agree with you that the liver is resectable, the rectal cancer also resectable, but a bit tricky on the lateral node. It's still resectable because we see the margin of it is actually located at the internal iliac group, not the obturator, and there is no invasion deep down to the vessels. It's just on top of it. So that means we still be able to find the good plane for the resection. So in this case, we proceed to the surgery. So shall we see it? So let me tell you what we see. In this case, we start with liver first. I mean liver simultaneous resection. And this is the reverse surgery. So we get to the good margin. It took less than 2 hours. And after that, it's followed by the rectal surgery.
So did you do the liver by yourself?
No, liver surgery. Just only colorectal, I think is easy enough. So in this case, the rectal dissection is as usual. We find the TME plane. Thank you. And the dissection proceed down to the pelvic floor. And this is the anterior dissection. So the pelvic exposure is so important. So we use the hanging stitch to hang the bladder fat. And this is the lower dissection. Now it's time to staple the lower rectum. And this is the lateral node dissection. I will tell you later on about how I place the port. But you see, obviously, I still standing on the right side of the patient, not moving to the left side. I used to do that also, moving to the left side, but in my opinion, have a bit change to the right. I mean, stand on the right. I still comfortable to do. So this is the section to the obturator. Now we start to see the obturator nerve. So basically, you see my right hand instrument come from somewhere very close to pubic symphysis, suprapubic port, but slightly deviate to the right. Now the obturator group is already done. So we remove the obturator group first. And because the node is occupy the left internal iliac vessels, so we start to dissect and decided to cut some vessel to be the margin of this lymph node. So the vesical vessel is identified and transect. And this is umbilical. And now we get to the good margin on this location. So by doing this, we scoop everything out. No preservation of the the vesicle vessel.
So basically, you can reset all the arteries.
Yeah.
What you need to preserve is the obturator nerve because just one side, basically, you can take out everything.
But the nerve on the on the middle side still preserved. Okay, we can go to the pathology report. So here's the pathology report. So it's metastatic lymph node positive at the perirectal, and the internal iliac also positive. So it's all negative margin for this case. So would you give us some comment on this approach?
Yeah. Usually I'm gonna keep the superior vesical artery intact, and then all the other lower tributary of the internal iliac I'm gonna remove en bloc with the specimen. I usually en bloc together with the specimen is gonna be continuous specimen with the obturator nodes too. In this particular case, I agree with cutting all the branch of the internal artery because it's encased, the node is encased or everything.
I think it's a very good surgery, and eventually you can cut all the vessels except for the majors. Even though you can ligate internal iliac artery, that will be fine. What if the tumor is encasting the obturator nerve? What would you do? So we have to let the audience know that once you injure is it okay to resect the obturator nerve?
For me, if the patient good surgical outcome, I would discuss with the patient about the resection of the obturator nerve.
Yeah. So don't worry about obturator nerve because we were taught to not to injure it. But actually, once you injure it, I mean, I don't think a lot of patients would feel different the next day. Because once when we started to do the pelvic lymph node dissection, Romina was practicing on my cases, and she accidentally cut the obturator nerve initially. But I was so worried, but the next day the patient is okay. So I think when the nerve is injured and the nerve is encased by the tumor, just resect it.
If the patient like to do Thai boxing, they cannot do knee like internal knee.
Adducting function is going to be, if the patient is OH, I don't think.
Yeah, but the point is you need to save the life first, all right? If you oncology, if you can achieve a clearance, then you can not play the Thai boxing anymore, all right? So to save the life. So I think it's the point is I think you can take it out if it's in case. I think it's no problem.
Yeah, just a few minutes. I want to ask someone how would they do this type of case in the US?
They do the same. So I think that George Chen, Benaski, Nancy Yu, they do surgery the same way, which is very similar to our Asian country. Yeah, because they are Asians.
Do they do pelvic lymph node dissection? Do they believe in it or they don't?
There are groups that believe in that. So we have a paper that retrospect to see the outcome from that.
Many Western people that do not believe in this, right?
Yeah.
That's obesity.
Yeah.
But as you know that Konishi told everybody that if they say it's obesity, that's not right, because obesity do not alter where we're gonna do the lymph node dissection because there's no obesity in that area.
Yeah. The interesting issue in this case is how you use the port, because it's right side
I
and
did not say where is the port.
because
Stand up. So, this is my belly button. So for my right hand side, I put it here. Yeah, suprapubic, but a little bit slant to the right. So this is a suprapubic fold. So it allow me to go really deep down to the pelvic dissection. And on this side, I can work on the lateral node also.
Yeah, but it's different is that everyone has to go inside there and practice your left hand. Because Professor Chucheep is lefty. So it's easy for him to come to the right side pelvics, right? But for us, our left hand cannot be as free as yours.
And for my left hand, this is my belly button. Is here
Yeah.
on this.
See.
So it's gonna be like this,
Yeah.
like this. And I flip the patient super left up.
A little bit upwards. Yeah.
So don't do this at home. Except you have left-handed control pretty good.
Okay, so I think it's a good discussion for this case. Shall we move to the next one? We run out of time. We have some time for the third case.
Thank you. Thank you, Dr. Chucheep. This is a last case, the female, 64 years old, no underlying disease. Her BMI was 15.7. He presented with obstructed rectal cancer with vaginal invasion, bilateral groin node metastasis. Digital rectal examination showed the circumferential mass protrude from the anus fixed with the posterior vaginal wall. And the PV found the irregular mass at the posterior vaginal wall. So in that day, she underwent the left diverging loop transverse colostomy with rectal biopsy, and simultaneously we do the bilateral groin node lymph node dissection. And pathologic reports show the moderately left differentiated adenocarcinoma in the rectum, and the groin node it show metastasis adenocarcinoma, both groin. So this is a first MRI rectum before the neoadjuvant treatment. Okay, so you can see the primary tumor is very large and invaded to the vaginal. And here is a bilateral groin node, which we already dissected at the first place. Okay.
Also, this is a preoperative, I mean pre-treatment MRI. All right, so this lady has very low rectal cancer invading to the vagina, and you see the protrusion of the mass like that. So what is your comment on this? May I ask, Simon?
So it's a very bulky tumor. I noticed that the patient has got bilateral groin lymph nodes as well. All right, and dissection done, right? So this is, you can consider this as a metastatic disease already. All right, so it's because it's got bilateral groin lymph node metastases. So, but anyway, you have done that. You have defunctioned it. You have taken out both lymph nodes. So I think it's obviously, I think again, this is not young, right? 60-year-old, but it's so bulky tumor. I would go for TNT for this, you know, after lymph dissection, and then for the long course RT, I will cover the groin area as well.
Me too.
So would you consider the groin node in this area localized disease or metastatic disease?
Controversial, I would say. It's
If it's a inguinal node, the node there, I'll consider it's a systemic disease.
Yeah.
For me.
Actually, this is my case. So, I saw the case before. But in my point of view, if there's no distant metastasis obviously seen, I usually do the groin node dissection when we have the clinical groin node positive.
So you do dissection
Yeah,
anyway.
always, yeah.
Okay.
And then because as you guys said, it's controversial. I need to give them a chance. However, I would do the dissection before radiations because if the groin node is huge and then radiations and then the groin node is getting smaller, but still I need the dissection anyway because I believe that it is kind of local disease too, right? Because it look like the lateral node dissections and then groin node for the very low rectal should be, yeah, is controversial, right? So I cannot do dissection.
Oh, groin node is probably for me, I'll take it before radiation.
Yeah.
Because first of all, I want an adequate pathology. See whether the nodes is comparable with the biopsy of the rectum.
Yeah, and then the radiation fields
What
cannot
if
cover
the
that.
nodes comes out to be squamous cell carcinoma?
Just radiations.
Radiation.
No,
And the
no.
rectum is called adenocarcinoma.
Then you need to search for SCC focus. I think it's, but I agree that I would also do it. Just consider your lymph node dissection. I mean, the groin as a biopsy. Bilateral, both. And drink your.
Bilateral, I probably the one side for that. My point is sampling for an adequate pathologies. Secondly, you can obtain your RAS typing.
Yeah.
And if it's wild type or it's mutated, if it's wild type, I probably will place patient of Fafazeri plus Panelist.
But probably some consider it as still a local, so your lymph node is a therapeutic one, not just an biopsy. You get some histology. So I agree. Yeah, if you think that way, I think it's okay to take out both sides.
And another reasons that I do before radiations. Another one is after radiation because we're gonna include radiation fields in the groin nodes too. And then after radiation, the skin and everything is very hard, and do dissections, aggressive dissection, and after radiation is terrible. Lots of wound complications and high leak. So I do it upfront. So what do you think about the induction or consolidation? We all agree that this case should receive the TNT, right? So I'm not sure induction or consolidation is better.
No, to me, it doesn't really matter because unless you're talking about watch and wait, obviously will not be a candidate. All right. If you think about watch and wait, probably consolidation will be better based on the opera trial and experience. So, but anyway, we just want to give more chemo beforehand. So either induction or consolidation will be okay. I'll do induction for this case. Probably 4-4 series triplet, and then a long course chemoradiation therapy covering both as well.
So in this case, because this is adenocarcinoma, that's why we are talking like this. But if the biopsy turned back to be, squamous cell cancer, it's maybe different story, right?
Primary tumor, right?
Yeah.
Not like Prof. William said, like the primary is adeno and then the node is squamous.
Unless we talk about the differentiation or adding or that kind of thing. Otherwise, I think it would be just an news.
Where do you see a groin node for adenocarcinoma?
Well, unless
rectum.
it's very, very low anal.
Yeah,
Theoretically,
unless
the
it's very low.
nature of the anal canal because the thing actually invaded through the anal canal, right, coming out. So theoretically, it's possible.
Okay, please proceed.
Okay. So unfortunately, she cannot afford any targeted therapy. So we not done the study, and so she got the modified for FOX6 for 11 cycles, then long course chemo RT, and then we follow the MRI rectum as 8 weeks after the RT. Yeah, still imaging.
And the RT cover all the
Yeah,
Groin as well.
cover the lateral groin
Right.
area as well.
Extensive radiation.
Yes.
Okay, now we see significant improvement after the treatment. I have to ask Songphol, right? Because he is the one who examined on the patient. What is the examination at this point?
Well, the tumor is shrink a lot, still have some irregularity, like in the rectum, but in the vagina, I just feel the thick scar, posterior wall, like but the scar is long, yeah.
All right. So in this case, do you have any case that seem to be very big, but it's turned to be like complete response?
I think yeah, interesting. If huge tumor turn out to be complete response, especially in this case, if we have to do surgery, it's going to be APR together with the en bloc vaginectomy. If it's CCR, I would discuss hardly with the patient if we have to do wash and wait or not. Yeah, but you know, the data always said that the T3, T4, they're gonna regrowth anyway, and then when it regrowth, it's gonna have like distant metastasis. It's very hard for me. I'm gonna do radical resection anyway. Yeah, even though it's CCR in this case.
Yeah, I agree with Songphol. I think we'll just go for APR and then posterior vaginal en bloc. That's you're just looking at this so bulky, right? The actually now the chance of having it to have a CCR it's not high, I would say. Even if it's a CCR, I think the chance of tumor regrowth, as mentioned by Songphol, will be quite high. All right. Probably you can just defer your surgery for a very short while, and then you're going to see the regrowth very, very quickly. All right. And by the time it has regrown, probably there's already distant mets as well. So you need to consider that as well. So I'll just go for APR for this case.
This case is the tumor is touching the posterior wall of the vagina. I don't think it's in my practice. I don't think I'll place a patient and watch and wait because it's already a T4 lesion, and I never see any T4 lesion that ended up with a CR, chemo radiation. I mean, at least by practice, I never see any T4 lesion that ended up with CCR. So I will take them to surgery for APR, laparoscopic or robotically. It doesn't matter what, but never transanal.
Okay, so it's all agree for the go button, right? You proceed with the surgery. So William, you feel that this is not a good case for the bottom up? Can you?
I don't do button up for APR. People does. I mean, Peter
Chen,
does.
Peter Chen,
Yeah, but I don't.
I know we don't.
But Peter, I saw him a couple of times. I invited him for live surgery, but I don't see very it does not convincing me. I mean, of doing it. Yeah, maybe it's me, but I can do it robotically or laparoscopically from the top till the end. Yeah.
Simon.
Because I agree. This don't need to transanal because anyway it's a perineal dissection. All right. The difference is whether you just under direct vision you're in size or you because for transanal APR like what Peter Chen did, he still need to make an incision around before he can, and then you use purse string whatever, and then you put in your gel point pad, and then you carry on your dissection. But I think personally, I think just under direct vision is okay. And for this case, top down doesn't matter because the problem is at the perineal side. You do the vaginal perineal. You can the question is whether you would like to do it in a lithotomy or a project knife. So that's a different story, all right? But it must be top down lab or robotic APR? for
I'll
this
do
case?
APR, and at the end, I'll flip the patient up and I'll put the patient in prone jack position. I like to do it that way because
Yeah,
I can
yeah.
see it directly.
Yeah, yeah.
All my APR is at the end, I flip the patient over.
Oh, all cases, really?
Yeah, yeah.
Oh.
I want to make it simple for myself instead of staying underneath like this. Yeah.
In this case, for sure, we have to cut the fair amount of the vagina, right?
Yeah.
Because we see the involvement of the posterior vaginal wall. So definitely we have to find something to do the reconstruction. What is your comment on this?
Because we don't know how to do a colonic flap, right? So we need to get in the plastic people to do whatever flaps they can think about, right? Like it. Well, they love to do. They use ALT or gracilis, but it's up to them, right? Obviously. How old is it? 60 something.
Gonna do a sigmoid flap, taking a sigmoid colon to use it as a reconstruction for vaginal. Is that right?
Because this is not my
I
case.
did it only once.
You have to ask the
I
surgeon.
told you, I did it only once, laparoscopically, back a long time ago, but after that, nowadays we're doing it for transsexual cases. Yeah, we do it because our plastic surgeon needed us to bring the sigmoid down. And for male to become a woman, we need to go to the tunnel perineum. So we do that for them. So nowadays we do sigmoid using laparoscopy to take that to harvest that.
And your position is very interesting because you're gonna flip the patient on the prone for the final part for the APR.
Resection of the for APR. I like to do it at the final position in the prone. There's literature showing that it'll be better if you do a prone. And because I'm so familiar with jackknife position, I do all my hemorrhoid in the jackknife position. Yeah, so I feel much comfortable with flipping the patient.
I mean, it's a matter of really depends on, yeah, and it also depends on what the plastic surgeons are thinking about the reconstruction. Local flap, probably a prone would be good, but if I do, probably just keep it as up. So it's up to what kind of reconstruction you're thinking about to decide on the position.
Yeah. Because I'm Chula, I need to use vaginal flap and a colonic flap because if I do others, Prof. Chucheep gonna come into my rooms and say, "Hey, what kind of flap you use?" I think at the end of the procedures, in this case, we're gonna have very small strip of the anterior wall of vagina. I need to cut all the posterior wall of vagina and the lateral wall too, because before surgery, because radiation, that all the tumors go into the vaginal canal. So it's gonna be very, very small strip of urethra and the anterior wall vagina.
Shall we see the video?
Yeah, and it's gonna be very hard for using other kind of flap to reconstruction.
So you can narrate this video for us.
Here's the IMA thing. Here's the flap preparations. I keep the left colic artery as the pedicle of the flap. Resect the superior rectal artery, and that's the IMV at the same level. The lateral dissections as usual. And then the TME, that's the posterior dissection plane. And then the section at the anterior side. And I see the vaginal posterior wall of vagina there. And that's the pelvic floor coccyx. And I usually cut the pelvic floor from inside out. And also the ischioanal fat from inside out too. You can see ischioanal fat there. Just the level of the tip of the coccyx. I do it all around like that. That's the ischial fat. And then I let our assistant push the vagina and cut the posterior wall vagina from inside. And then connect with the dissection plane through the pelvic floor laterally. That's the flap, the sigmoid flap that I gonna use for the neovagina. I'm gonna disconnect that colon proximal for the end colostomy and the distal for the conduit for the neovagina. Here you can see all the vessel that cuts and the pedicles. And now the resections turn to the perineal resections. That's the vagina and the scar. I'm not sure if they gonna do the TATME, how they gonna put gel point into the vagina and just the anterior wall. So this section is easy from below because I do the dissection from above already. So you can see the urethra there. That's the vaginal wall. That's the urethra and the small strip of the remnant of the anterior wall vagina. Use the colonic flap, spatulate the antimesenteric side, and connect with the anterior wall vagina. And that's it.
Oh, all right. So in this case, it seems that the surgery done well, T4 and 0. So do you have any comment on the approach, Simon?
I just want to congratulate Songphol. Very nice, excellent surgery. Nicely demonstrated, everything just clear. So, yeah, perfect.
Well done. Well done.
Yeah. So so this is
There's one thing I want to ask, the end stoma, did you take down spleen friction? No, so it's long enough to come out?
Can I just ask, if this case you need to do an anastomosis down there? It's a very low resection. You need to do a very low coloanal. Does it really matter if you take out part of it and then fashion a colonic flap technically? Because this case is an APR, so it's fine because it's going to be end colostomy. What if you need to do it, bring it down to the very lower pelvis and do an anastomosis? Would that be a problem if you do the colonic flap?
Usually if we can do the anastomosis, we not usually use the colonic flap because we don't need the things to cover the inlet. Yeah.
So what if you gonna do it in anastomosis? What kind of flap that you use?
you mean anastomosis and then vaginal reconstruction?
Yeah.
That is a very good question. But the good thing is when the tumor heavily involves that part very close to the lower part of the vagina, is always involved the sphincter. But if it happened to be a bit upper part, so we just cut it. We just do the hysterectomy, like anterior excenteration, and vagina can be closed. You will have like short vagina like that.
Usually I will take, for this kind of case, I would also take the interior surgery.
Yep.
So it'd be easier for me to do reconstruction and.
Yeah.
But I see that you saved the uterus.
Yeah, I used to do. Yeah, yeah, yeah. I used to use the anterior vaginal wall after I removed the uterus and flip the anterior vaginal wall, flip down to the posterior part. I used to do that also. Flip it that way when I need to cut very wide resection. But colonic flap is easier, much easier. I think we about to be on time, and it's a good case discussion. I think we see that the most important is the surgical planning and look at in the individual case what is the approach that we can get the good clear margin, and you see that the tactic before the surgery still very important part. So we need to work in the MDT, and this is what I can conclude in our discussion.
I was wondering is the audience, they don't have any questions. Do you guys all agree with we 6 here? Or you have different thinking in the cases?
Thai surgeons is a bit shy. Yeah.
Not like us, right?
All right. Any comment from the floor or suggestion?
Yeah. I think you guys are also involved in the MDT, right? They also sit in. So I think it's a great learning opportunity. So I understand because when I was a junior, when I sit in these kind of MDT, usually most of the trainees will. Yeah, all right. Usually,
Who drives the MDT in your center? Who drives the MDT?
Surgeon?
Surgeon or
Surgeon.
oncologist?
Surgeon in charge.
Surgeon.
Yeah.
And I think for the young generation and the other hospital, probably you may need to consider to set up their own MDT in the institute. Very important for combating the cancer disease, not only for the colorectal, but the other discipline as well. Very important. Please consider that.
Yeah, for the training, I think MDT probably can, or it's about how to read MRIs. I think that's important. Don't rely on the radiologist. So you yourself should be able to interpret the MRI yourself, all right? And then to update yourself on the literature because the whole thing is evolving so rapidly, all right? 5 years ago, we never heard about TNT. Now it's a norm already, all right? So it's in process.